Hello everyone, welcome back to my channel, that is Obstetrics and Gynaecology Simplified. Today we will be learning about ectopic pregnancy. So what is ectopic pregnancy? Ectopic pregnancy means that is the pregnancy that is present outside the uterus. So the pregnancy that is present inside the uterus, that is the intrauterine pregnancy, okay, that is present inside the uterus, which is normal. But if it is present outside the pregnancy, that means it may be present in the fallopian tube, it may be present in the ovaries, it may be present in the abdominal cavity or the peritoneal cavity, it may be present in the cervix or the scar site. Okay, so these are the ectopic pregnancies which are very critical for a mother. So it can take a life. So we have to know the management, how to diagnose ectopic pregnancy. It is very important to clinically examine the patient and diagnose a critical case so that we can save a life. Okay, so let's start. Coming to the incidence and risk factors, see, from the normal pregnancies, only 1 to 2% are ectopic pregnancy, but only 1 to 2% is the of all pregnancies are the ectopic pregnancies. But this is very important, we have to diagnose, okay, so that we can save a life. Then out of that, 95% is tubal and other 3% is non-tubal. So from the non-tubal, it may be cervical, it may be cesarean scar ectopic, it may be intestinal also, okay, from the tube. So where does the fertilization takes place? The fertilization takes place in the ampulla of the fallopian tube. So it can come to the uterus to become intrauterine pregnancy, or it can go through the fimbria and gets deposited in the ovary or in the peritoneal cavity and become ectopic pregnancy. It may also land up as intestinal pregnancy. So it may be intestinal, it may be cornual pregnancy. Cornual pregnancy is not intrauterine pregnancy. Why? Because what is cornual pregnancy? Cornual pregnancy means if the gestational sac is present in a cornu of the uterus. Okay, that may be rudimentary also. So if it is present in the cornu, that means in a biconvert uterus, if the gestational sac is present in one cornu of the uterus, that is also called as ectopic pregnancy. And there also we have to do the surgery, we have to remove the gestational sac, or there are chances of rupture and hemodynamic instability of the patient. Okay, then also ovarian and heterotopic as well as abdominal. So these are the non-tubal pregnancies. So 95% are the tubal, but unusual, that is 3%, that may be cervical, cesarean scar, intestinal, cornual, ovarian, heterotopic and abdominal. What is heterotopic? Heterotopic means it is present both in intrauterine as well as the extrauterine. Okay, then what are the risk factors? In India, we are more predisposed to the genital tuberculosis. Okay, so it is TB prevalent area. So the most common cause is genital tuberculosis or pelvic tuberculosis. That is the most common risk factor. Then 13.2% times, or the incidence is 13.2%. Okay, that means it is so much common, that is the genital tuberculosis and pelvic tuberculosis, that must be sampled at surgery. We have to take during the surgery when we open due to hemodynamic instability of the patient. If we open or laparotomy is done or laparoscopy is done, we have to sample that pregnancy. We have to send it for the histopathological and cytological study. We have to know that it is tubercular origin, so that ATT can be given, anti-tubercular treatment can be given to that patient. Okay, then what are the other risk factors? It can be PID, that is the pelvic inflammatory disease, and the most common is previous ectopic pregnancies. Okay, so previous ectopic and IOD related conception and tubal surgeries or tubal ligation, also STIs, smoking and infertility, or in ART techniques also, that is artificial assisted reproductive techniques also, there are no chances of ectopic. Okay, so most ectopics have no identifiable risk factors, that is we have to diagnose it clinically. That means what are the clinical things we have to see? First, there will be amenorrhea, then pain, and bleeding. That is APB. Okay, amenorrhea, pain and bleeding. This is the clinical triad in the ectopic pregnancy that we have to identify. So, what are the clinical presentation? The classical triad, I have told you now. What is the classical triad? Amenorrhea, pain and bleeding. Also may present as fainting or collapse and dizziness, breathlessness. Usually these symptoms arises when there is ruptured ectopic. Okay. So what are the uncommon symptoms? Uncommon symptoms can be shoulder tip pain, because of the hemoperitoneum. Okay, that is the fluid accumulation. If the tubal ectopic is ruptured, so there is hemoperitoneum that is bleeding from the ruptured ectopic side. So there will be hemoperitoneum and that will irritate the diaphragm. Okay, so the diaphragm will be irritated and hence there will be shoulder tip pain, because through the phrenic nerve, as it supplies both the diaphragm as well as the shoulder tip, so there will be shoulder tip pain due to hemoperitoneum, irritation of the phrenic nerve. And then other symptoms can be rectal pressure due to hemoperitoneum, diarrhea and urinary symptoms. Also anemia, and anemia is not uncommon because in ruptured ectopic due to bleeding there are more chances of anemia. Okay, then on examination, what we see on examination in unruptured ectopic, there may not be any symptoms. Patient may be absolutely normal. Okay, she may behave as normal intrauterine pregnancy, or that she may not present also. Okay, it may be incidental finding during routine investigations or any ultrasound scanning. Okay, in ruptured ectopic, there will be symptoms of shock, that is tachycardia, hypotension, tachypnea. Okay, and cervical motion tenderness, adnexal mass tenderness, and POD fullness, that is pouch of Douglas. Okay, also the POD may be tender. Okay, then hemoperitoneum, if it is present, it is very dangerous. Okay, so in case of hemoperitoneum, we have to see the abdominal signs, and also if the vitals are altered, that means the hemoperitoneum is present and immediate surgical intervention is required and urgent resuscitation is required in this case. So this is a medical emergency in case of hemoperitoneum. Okay, then coming to the diagnosis, how will we diagnose the case? Okay, if that is ectopic pregnancy or not, first we have to do the urine pregnancy test. In urine pregnancy test, first UPT will be positive, plus the patient will have amenorrhea, pain plus bleeding, and it is, if these three are present, so first we have to diagnose as ectopic pregnancy unless otherwise proved that it is intrauterine pregnancy. So first we have to think about that the case may be ectopic pregnancy unless proved that it is intrauterine pregnancy. Okay, then we will do serum beta hCG, but single value is not, its single value is not reliable. and it does not localize the pregnancy. Single value does not localize pregnancy. We have to take two values, that is 48 hours apart. Two values 48 hours apart. In intrauterine pregnancy, doubles. Beta HCG doubles every 1.4 to 2.1 hours. Okay. And in, if less than 50% rise in beta HCG, that means ectopic, but there may be exceptions. Okay. In also in some healthy intrauterine pregnancy, there may be slow rise in the beta HCG. Okay. So, and also viable ectopic with normal doubling. Okay. There may be, there are a few exceptions. Okay. But these are the things. Okay. Then we can do transvaginal ultrasound. In transvaginal ultrasound, this is the mainstay investigation. This is the mainstay investigation, and here we see both uterus and adnexa. What is adnexa? That is the tubes and ovaries. So we see uterus and adnexa, and in tubal ectopic, non-cystic adnexal mass is seen separate from the ovaries. Okay, and it may contain gestational sac, yolk sac, fetal pole. Okay, plus minus it may contain. Okay, and empty uterus plus empty uterus. Okay, then MRI. So, is the MRI done routinely? No, the MRI is not done routinely. But if we are suspecting, or ultrasound is done and then we are suspecting any cervical ectopic or cesarean scar ectopic which may invade into the bladder also, there we have to do the MRI so that proper delineation of the mass is done and we can plan the surgical management accordingly. Okay, so MRI, it is for the unusual sites. That is cesarean scar, interstitial. Okay, then abdominal, or if there is uncertain diagnosis. Okay, then we have to do MRI. Serum progesterone, if it is more than 25 nanogram per ml, that means it is viable pregnancy. Okay, and then a routine endometrial curettage to look for the area stellar reaction, because in ectopic pregnancy we have the area stellar reaction, that is the endometrium is grown because of the effect of the trophoblastic mass. Okay, when the trophoblast, it secretes the hormones that helps in growth of the endometrium. So due to withdrawal bleeding, so there that is called as the area stellar reaction. So routine endometrial curettage to see the area stellar reaction is not recommended according to the FOXIT 2020. So we do not need to do the endometrial curettage routinely. So these are the proper investigations. First, for the diagnosis, we have to do urine pregnancy test. In urine pregnancy test we have to do the UPT. If it is, it should UPT positive, and there will be presence of amenorrhea, pain and bleeding. And if, unless it is unless we are able to prove that it is intrauterine pregnancy, we have to take it as ectopic pregnancy. That is the first. And secondly, we have to do the serum beta hCG, and also single value of the beta hCG cannot localize the pregnancy. We have to do two values. In two values, we will do 48 hours apart. If we are doing today, after 48 hours, we will be repeating the test. In that test, if the beta hCG is more than 50%, if it is rising, then we can conclude it as viable intrauterine pregnancy. But there may be some exceptions. But if it is rising less than 50% or slow rise, then we may suspect ectopic pregnancy. Okay, then but transvaginal ultrasound, that is the mainstay. That is, we can localize where the ectopic is present, and that is the thing we can see in the uterus and adnexa, and the localization of the ectopic pregnancy. Okay, we can directly visualize for the gestational sac, yolk sac, or cardiac fetal pole. Okay, with the with the empty uterus. The uterus must be empty. Okay, then an MRI for the unusual sites. I've told you, and progesterone more than 25 nanogram per ml. That means viable pregnancy, and routine endometrial fluoridage is not required. Okay, then what is the management of the ectopic pregnancy? Foxy 2020 recommends the management. We can just divide it into medical management and surgical management. So, just answer me a question. Can we do the medical management in all ectopic pregnancies? No. Okay, we cannot do medical management in all ectopic pregnancies. So, there are some eligibility criteria. The patient must fulfill that criteria so that we can do medical management. Okay, so there are some eligibility criteria, how to monitor, and what are the dose, what are the things that are given in the medical management, that we will discuss. Okay, apart from that, every other ectopic pregnancy we have to do the surgical management. So the patient not fulfilling the only that few eligibility criteria, medical management is not preferred. We have to do the surgical management. That may include salpingostomy or salpingectomy. That I will be telling you in details later on. Okay, so in medical management, we give single dose methotrexate. Okay, that is the drug we are giving. That is methotrexate. You have to remember, methotrexate single dose is given. Medical management for. So what are the eligibility criteria? First, the patient must be hemodynamically stable. She must be stable, so that we can just know what are the eligibility criteria. The patient must be stable. That is the first and foremost point. Okay, so the patient must be hemodynamically stable. Hemodynamically stable, and the ectopic is confirmed. Ectopic is confirmed by TBS. Okay, patient must be hemodynamically stable, ectopic must be confirmed on TBS, and mean side diameter is less than 3.5 cm, cardiac activity is absent, beta hCG is less than equal to 5000 international unit per liter, and no signs of rupture, and patient has access to emergency care. So these are the specific eligibility criteria that the patient must fulfill, so that we can advise the medical management. Okay, so what is the dose of the methotrexate? The dose of the methotrexate, see here, that is 50 milligram per meter square. IM single dose is given, 50 milligram per meter square. How to follow? We have to do beta hCG on day 4 and day 7, and we have to do the beta hCG on day 4, day 7, and the values or the drop should be more than 15% from the day 4 to 7. So first we will do day 4, and then again we will do it on the day 7 beta hCG. So the day 7 beta hCG must be the drop must be more than 15%. Okay, that means the medical management is successful. Okay, then After that, we have to do weekly beta hCG till the value is negative. Okay, then if the drop is less than 15%, then we have to repeat the second dose of the methotrexate. Okay, and do the day 3 beta hCG, and if no drop even after 2 days, okay, then we have to do surgical management. So what we know from here, that there are only few specific criteria, eligibility criteria to give the medical therapy, as well as we have to monitor the patient by using beta hCG, and also if that fails, we have to do surgical management. So you just imagine, final destination is our surgical management. So there are only few criteria where the medical management is preferred. Okay, so then, and what are the contraindications to medical management? The contraindication of the medical management, that is the indication to the surgical management. So what are the contraindication? Contraindications are hemodynamic instability, heterotopic pregnancy. That means if both in both in uterus also the gestational sac is present, as well as the G-sac is also present in the tubes, and we do the laparotomy or laparoscopic tubal excision or salpingectomy is done, but the pregnancy is also present in the uterus, intrauterine also present, that is the heterotopic pregnancy. So is the treatment is complete? No. So in heterotopic pregnancies also we cannot do the medical management. Okay. Signs of rupture, or if hemoperitoneum is present, and active tuberculosis. Okay. Methotrexate hypersensitivity, as the methotrexate is a drug, so drug hypersensitivity, that is the methotrexate hypersensitivity also we cannot give, and in breastfeeding individuals also. Okay, then coming to the surgical management. So what is the indication of surgical management? If G-sac is more than 3.5 centimeter, even if the patient is stable but the gestational sac is more than 3.5 centimeter, beta hCG is more than 5000 international unit per liter, and cardiac activity is present. Okay, or failed expectant management. Failed expectant or medical management, we have to do surgical management. Okay, what is the approach? So surgically, what are the two options that we have? We have laparoscopically or laparotomy. Okay, according to Foxy, salpingectomy is preferred. So see, salpingectomy is preferred according to Foxy. So what are the indications? Indications is if the tube is ruptured or damaged, and also if the patient is unstable. So in unstable patient, the first line is salpingectomy, that is the surgical management. So what is the prerequisite? Contralateral tube should be normal. Okay, infertility desiring patients. Otherwise salpingostomy can be done, and it eliminates persistent trophoblast and ectopic in the same tube. If the whole tube is removed, so that means whole of the trophoblast is removed and no remnant is there and no recurrence is there from that tube. And also if we remove the tube, there is no chances of the ectopic in the same tube itself. So there is decreased chances of ectopic in the next pregnancy because the tube itself is not there. Okay. Then coming to the second option, that is salpingotomy. So here only a cut is given in the tube and the G-sac or the gestational sac is scooped out, and the tube is left open. So that is done in unruptured ectopic with fertility reducing factors. Okay. Prior ectopic contralateral tubal damage or prior PID or surgery. Okay. So what is the risk? Persistent trophoblast, because we cannot remove whole of the trophoblast, because we cannot see in naked eye. Okay, so there may be presence of a few trophoblastic tissue in the fallopian tubes. Okay, so that needs beta SCG follow up, and also we may need rescue methotrexate or salpingectomy later. Okay, so finally these also have the risk. Salpingotomy, we have to do follow up, we may need methotrexate, we may need salpingectomy also, and follow up we have to do weekly beta SCG till less than 5 international unit per liter, that is negative. And for the non-tubal ectopics, that is interstitial ectopic, first how to diagnose in ultrasound in interstitial ectopic. That means in the interstitial part of the fallopian tube there is presence of the ectopic. The uterine cavity is empty. Gestational sac is in the intramural part of the tube and surrounded by less than 5 mm of the myometrium in all planes, and also the interstitial line sign is positive. So what is the treatment? First line, we can give medical treatment if the patient is stable. What are the surgically we have to do maybe laparoscopic or open corneal resection, and salpingotomy if fails or bleeding occurs. Okay, or maybe salpingectomy. For convolular rudimentary horn in ultrasound, how to let's see, this one is present in the biconvex uterus. Okay, within rudimentary horn, there is a gestational sac, it is present in the rudimentary horn of the biconvex uterus, that is called as the corneal ectopic. So a single interstitial tube in main uterine body plus gestational sac in the rudimentary horn plus completely surrounded by the myometrium and vascular pedicle to the unicornuate uterus. Okay, understood? And what is the treatment? So we have to excise the rudimentary horn where the ectopic itself is present. The horn itself is removed. Okay, then we have to assess for the other urinary tract or renal anomalies, because often it coexist with the Mullerian anomalies, that is in bicornuate or unicornuate with rudimentary horn corneal ectopic is found, so that is a Mullerian anomaly. So that is also associated with the other that may be associated with other renal anomalies. So we have to assess for the associated urinary tract anomalies. Okay, then coming to the ovarian ectopic, that is when the ectopic is present in the ovarian tissue. That means uterus is empty first, then echogenic ring on ovary, and also negative slide sign, and corpus luteum separate from the mass, as well as the free fluid is present. Okay, and what is the treatment? Laparoscopic enucleation or wedge resection of plus minus oophorectomy. See here, if this is ovary, and here if ectopic is present, we have to do wedge resection of the ectopic, and then we have to repair it with catgut sutures. And if uncontrolled bleeding, then we have to do oophorectomy, salpingo-oophorectomy. Okay, then in cervical means the ectopic is present in the cervix. I have a separate short video of the cervical ectopic. You can just watch it there. Also cesarean scar ectopic ultrasound pictures and the management I've told you in another video. Watch it in my channel. Okay, and also an ovarian ectopic video is also there for clinical knowledge and how the ectopic looks, where is the location, what type of surgery is done. That video is present. You can just watch it there. And in cervical ectopic, how to diagnose? In ultrasound, the uterus is empty and the barrel shaped cervix is present. Gestational sac is below the internal os. Okay, and sliding sign is absent, plus perisac Doppler flow is present because of the increased vascularity to the gestational sac, because the gestational sac will need some blood supply. So that is perivascular perisac Doppler flow is present. And what is the treatment? We can do medical treatment, that is the first line, but surgery if we do, we have to do suction or hysteroscopic resection. If it fails, then uterine artery embolization can be done to prevent the bleeding or to stop the bleeding, or internal iliac artery ligation can be done, and balloon tamponade can be given to control the bleeding. In cesarean scar ectopic, that is this in scar side, in previous scar side the ectopic is present, so there also uterine cavity will be empty. The gestational sac or the trophoblast is in the anterior lower uterine segment scar site. Okay, and the myometrium will be thinned out, okay, between the sac and the bladder, plus there will be increased vascularity, plus cervix will be empty. Here what is the difference between the cesarean scar and cervical? Here the cervix will be, or the endocervical canal will be empty, okay, but in cervical pregnancy the pregnancy will be present, the G-sac will be present in the cervix itself. So below the internal os the G-sac will be present, but the cavity is not empty. Within the cavity the cervical ectopic is present, but in cesarean scar it is present in the scar, okay, in the myometrium, in between the myometrium and the bladder, okay. So what is the surgery that is preferred? Suction evacuation or hysteroscopic resection, or laparoscopically we can also do the resection, and also open scar excision with lower uterine segment reconstruction, okay. Then in heterotopic pregnancy, in ultrasound what we see, intrauterine pregnancy plus coexisting ectopic pregnancy on the ultrasound, means in the uterus also there will be G-sac, in other sides there may be gestational sac, okay. Here beta SH is of limited value, okay, because it raises independently. The intrauterine pregnancy it raises independently. In the ectopic, like this is very unreliable, okay, beta SCG. And in treatment we have to preserve the intrauterine pregnancy. In abdominal pregnancy, gestational sac is absent, intrauterine gestational sac is absent. Also the adnexal, there is no adnexal mass also, but the gestational sac it is surrounded by the bowel lobes, that is separated by peritoneum, and wide mobility, that will be very mobile. Anything present in the abdominal cavity due to large more space, that is more mobile, okay, that have no restricted mobility, more space is available, so more wide mobility on the transvaginal ultrasound. And also probe pressure, there is probe tenderness is present, and treatment should be early, that is the first trimester we have to do laparoscopic removal, but in advanced case, because if the size will be more, so we may need laparotomy also to be removed. And in case of pregnancy of unknown location, beta SCG will be positive, and in ultrasound also we cannot see the gestational sac even in the abdominal cavity, even in the ovaries, even in the uterus, even in the cervix, there will be no gestational sac. So we have to repeat serial beta SCG will be done, and we have to repeat scan, and highly we have to, like, clinical suspicion will must be high, and in persistent pregnancy of unknown location, methotrexate can be given, or else we can do the surgery. We have to know the location, okay. So how to diagnose the cases I've told you. Then what will be the future fertility counseling. Similar ectopic may be repeated. Okay. So what is the recurrence rate? It is 10 to 15%. So we have to counsel the patient accordingly, that you are having 10 to 15% chances that the ectopic may occur in the next pregnancy. Also that we have to be very careful. Early pregnancy scan must be done. Beta SCG must be done. Okay, we have to counsel the patient. And then we have to know that this is a very, the ectopic pregnancy, I've told you all the management. We have to know the how to diagnose, we have to know the risk factors, what do you mean by medical management, and what are the surgical managements that are possible. Okay, the clinical presentations, okay, all we have discussed. If any doubt or any query or anything else you want to know about the ectopic pregnancies, you can just add a comment below this video. Okay, so thank you and keep learning.